Okay, so today we're going to be talking about pulmonary edema on chest x-ray with some CT correlation. So before we jump into the chest x-ray manifestations, let's first talk about how to think about pulmonary edema. And there's several different ways of doing this. So you can either think about pulmonary edema as it relates to its pathophysiology or to specific causes. So let's first talk about pathophysiology. And for pathophysiology, we're really talking about Starling forces. So what are the Starling forces that can allow fluid to leak out of vessels? So the biggest one here is hydrostatic edema. This is where there's too much pressure inside the vessels. That pressure pushes fluid out of the vessel into the interstitium of the lung. That's hydrostatic edema. This doesn't have to be related to hydrostatic pressures though. If the vessels are leaky, right? So if they have leaky vessels, now fluid can leak out. And that's what we call permeability edema. And permeability edema we think about as either being related to diffuse alveolar damage or without diffuse alveolar damage. Diffuse alveolar damage we typically associate it with ARDS. So permeability edema with or without ARDS or diffuse alveolar damage. And then you can have a mixed pattern. So people with both hydrostatic and permeability edema. It can be kind of hard to remember which types of causes fit into each of these specific pathophysiologic mechanisms. So I think it's a little bit more helpful to think about them in causative. So what are the big causes? So the two big causes are either cardiogenic or non-cardiogenic. So for cardiogenic, this is related to congestive heart failure. So this is the biggest cause under cardiogenic. That makes sense, right? Under non-cardiogenic, the three big causes that we typically see are people that have too much fluid. So they're getting too much fluid or they can't get rid of the fluid. So who can get rid of fluid? People with like renal failure. So fluid overload or aggressive resuscitation. The other type of non-cardiogenic edema that we see commonly is ARDS. So this is going to be your permeability edema with diffuse alveolar damage. And then some specific clinical scenarios you just kind of have to memorize. And these are some ones that we see not uncommonly in clinical practice. So neurogenic edema, these are people with like intracranial bleeds, massive strokes, herniating across midline. This can cause a non-cardiogenic edema pattern within the lungs. Post-obstructive pulmonary edema, this is someone that has really bad stridor, either from a thyroid goiter or they're choking on a hot dog or something like that. And then they get intubated, the lungs re-expand rapidly against this negative intrathoracic pressure. This can lead to pulmonary edema. Re-expansion edema, these are people that have very large pleural effusions that are rapidly sucked out. The lung rapidly re-expands. That can cause unilateral pulmonary edema on the side of the re-expansion near drowning. Heroin and opioid overdose, that can cause it, and we're really dealing with this epidemic that's going on right now. So it's not uncommon to see these people that come in with an opioid overdose that are in non-cardiogenic pulmonary edema. Recent lung transplants, we see this as reimplantation edema. Within 24 to 72 hours, they often have this mild degree of edema that typically will resolve over the next week or so. And then lastly is TRALI, transfusion-related acute lung injury. These are people that are receiving blood products that causes an acute lung injury pattern in the lung. That's a non-cardiogenic type of pulmonary edema. So these are some causative ways to think about this. You just kind of have to have a bucket list, and these are some examples of some specific clinical scenarios that can produce non-cardiogenic edema. So what about the imaging appearances? So for me, the way I like to think about the imaging appearances, it's related either to some sort of hydrostatic process, so hydrostatic pulmonary edema, and here we see signs of elevated venous pressures. And we're going to talk about the signs of elevated venous pressures that will push us into thinking about hydrostatic pulmonary edema. And then we have causes that are not related to hydrostatic pulmonary edema. The classic scenario here is permeability edema with or without diffuse alveolar damage. So people with like ARDS, right? So this is non-hydrostatic edema. This would be like your opioid overdose or something like that. These are people that don't have to have elevated venous pressures. And then lastly, you have the mixed pattern. And the mixed pattern is really difficult, especially for trainees when they first start out. Even for attendings, it could be really difficult. These are people that are in the unit, they have ARDS, but they're also getting resuscitated with fluids, and they go into failure. There's some fluid that's transuding out into the lungs that's may respond to diuresis, whereas the diffuse alveolar damage obviously won't, right? So it's kind of a mixed bag. So for today's lecture, we're really going to focus on hydrostatic pulmonary edema and this concept of elevated venous pressures as kind of our signpost to say that this process is actually going on. So what are the major causes for hydrostatic edema? So one big cause here is cardiogenic pulmonary edema. These are people with typically left-sided cardiac dysfunction and acute congestive heart failure. So that's one of the biggest causes for hydrostatic edema. But you can also get hydrostatic edema if you just have too much fluid in your body, right? So too much fluid. So who gets that? People with kidney injury, so whether it's chronic and they miss dialysis, or it's acute and they can't get rid of the fluid, or they're being aggressively resuscitated. So this is kind of how I think about hydrostatic pulmonary edema. The two big causes, cardiogenic edema, volume overload. Who gets volume overload? Chronic people with some sort of kidney insult, either whether it's acute or chronic, or people that are being aggressively resuscitated with fluid. And the reason why I like to separate this out is because hydrostatic pulmonary edema, when they start developing pulmonary edema, it often corresponds, the signs correspond to pulmonary capillary wedge pressures. So normally pulmonary capillary wedge pressures are in the 6 to 8 millimeters of mercury range. This is usually acquired with a Swan-Ganz catheter. When you get to the 12 to 18 millimeters of mercury vein, you start developing vascular congestion. So this is kind of like the first phase of this. So you start developing vascular congestion. When you're in the 18 to 24 millimeter range, this is when you start developing interstitial edema. So now fluid is leaking out of the vessels into the interstitium. When you're greater than 24 millimeters, this is when you start developing airspace edema. So this is fluid that's actually not only in the interstitium, but it's actually leaking into the alveoli, going into the air spaces of the lung. Okay, so this is kind of the three phases: vascular congestion, interstitial edema, and airspace edema. And these things look different radiographically. So let's first talk about vascular congestion. So what are the signposts for vascular congestion? So we want to look for widening of the vascular pedicle, azygous vein distension, cephalization. And so to do that, what we really want to do is just blow up the central aspects of the cardiomediastinum. So we really want to focus on the central aspects of the chest x-ray, because this is where the signs are most evident. So let's just blow up that area. So let's talk about first the vascular pedicle, like how do we actually measure the vascular pedicle? So normal vascular pedicle width is somewhere between 35 and 58 millimeters in size. So let's take a look at how to do that. So here's a corresponding CT. This is a coronal CT. And the coronal CT, some relevant anatomy. This is your SVC, and this is your aorta. Now to measure vascular pedicle width, here's a schematic to show you how to do it. So what we do first is we have to establish the right boundary and the left boundary. So for the right boundary is formed where the SVC crosses the bronchus intermedius. So here's your SVC, and this is where it crosses the bronchus intermedius, so this area. You basically just draw a line straight through that. Okay, so this is the right boundary. Now, where's the left boundary? The left boundary is defined as the origin of the left subclavian artery. So here's your aorta, and it's the origin of the left subclavian artery, and that's this vessel right here. So where is that stuff on chest x-ray and on CT? So on CT, the SVC is obviously easy to see. It's this area in here. This is all the contrast within the SVC. Over here, the SVC and brachiocephalic veins, you can see as this density over here, this vague density. This is the outer edge of the SVC. And you can see where the SVC will come down and then intersect the bronchus intermedius. So it's this dot right here. So we want to draw a line through that. So let's do that. So that's where it intersects the bronchus intermedius. We drop a line down. So that's going to be the right edge. So what about the left edge? So here's the left subclavian artery coming off of the aortic arch. So this is the left subclavian artery. Where is that radiographically? It can be kind of hard to see, but here's the aorta, and you can see how there's a vessel coming off, like right here. This kind of like nice concavity. Okay, that represents the origin of the left subclavian artery. So once we find the origin of that, we drop a line straight down through it. And now we have our left margin. So we have a right and left margin, and then we measure the distance between those two, and this represents your vascular pedicle width. Okay, so here's a person that's going into congestive heart failure. And so on his first chest radiograph, what do we notice? We can see that the vascular pedicle width is actually normal in size. So here's the outer edge of the SVC coming down through the central airways here. And so we can see that it's normal in caliber. We also want to look at the azygous vein. So where's the azygous vein at? The azygous vein lives in here. It's nice and small in size. Typically the azygous vein in an upright chest x-ray should measure less than 1 centimeter in transverse dimension. So you can see that the azygous vein is nice and small in size and kind of tucked away. It's barely visible. And then lastly, we want to look at the vasculature. So here's the vasculature out here. So the vessels are actually in the upper lung zones, are somewhat small in size. And this can be kind of hard, again, for trainees when they first start out. What I typically do is, again, look at the vessels in the upper lung zones, kind of look in the lower lung zones. They look small in size. They look smaller than the vessels in the lower lung zones. If they do, I'm okay with it. And so you can see that the vessels in the upper lung zones look fairly small in size. Now, he's presenting with acute shortness of breath. And so what are the changes that we notice? So for one, the SVC we could see is just a little bit more prominent. It's off of midline more than what we saw last time, right? So we can see the SVC is all the way out here now, and then so we can see where it intersects the bronchus intermedius, so down here. So we drop a line. We can measure the width from the origin of the subclavian artery to the outer edge of the SVC there, and we can see that the vascular pedicle width has increased. It's now measuring 64 millimeters, greater than 60 millimeters, so it's widened. In addition, if we look at the azygous vein is much more distended than what it was before. Remember, it was a little small dot, it's barely visible. Now we have this kind of greater size ellipsoid structure at the tracheobronchial angle. And we measure it, and it measures greater than 1 centimeter, so there's azygous vein distension. In addition, if we look at the vessels in the upper lung zones are more prominent than what they were before. And I think, again, this can be really hard at first when you're looking at chest radiographs. It's really helpful if you have a prior imaging study, because if you compare the size of these vessels to what they looked like before, they just look bigger, right? So the vessels are becoming more distended. There's vascular redistribution going on. So this is an example of vascular redistribution. And then as we progress further in congestive heart failure, we see that there's further increasing widening of the vascular pedicle. In addition, this area is just becoming denser overall. It's filling up with fluid. The azygous vein, right, is much more prominent than what we saw initially. So we see distension of the azygous vein. And then the vessels, again, you just compare the vessels here to the vessels over here. The vessels are becoming progressively more distended and backed up, right? So this is all examples of vascular congestion. These are all the signposts of vascular congestion. Vascular pedicle widening, azygous vein distension, pulmonary vein distension with redistribution and cephalization. So what about interstitial pulmonary edema? So for interstitial pulmonary edema, what are the signposts that we're looking for that? So we're looking for curly lines, we're looking for peribronchial cuffing, we're looking for vascular indistinctness and hilar haze. We'll talk more about that. And we're also looking for fissural thickening. So here's an example of someone that has interstitial edema. Let's first recognize that he is developing hydrostatic edema. We know that because we see signs of vascular congestion. So for one, the azygous vein, right, is just standing out a little bit too much. It's too thick. It's too thick. In addition, the vessels, right, the vessels are standing up. They all look like they're giving each other high fives up here. They're just standing up on end. They're too prominent. They're just standing out too much. So we see that there is some signs of vascular redistribution. So what are the signs of interstitial edema that are present on this radiograph, though? And I think they can be really subtle at first when you first start trying to recognize these signs. So let's just blow up an area. We blow up that area, and we notice that there's all these little lines, right? So see these lines out here? Lines. We also see some lines more centrally. So what do these lines represent? These represent curly A and curly B lines. And once you know that they're there, when it's blown up, let's look at the other side. You can start to notice that you can see them over here too now. So those are your curly B and curly A lines. And what does that represent? It represents fluid leaking out of the vessel into the interstitium of the lung and thickening the secondary pulmonary lobule. This is what we call interlobular septal thickening. So as an example of interlobular septal thickening, both curly A and curly B lines are the exact same thing. Curly B lines are just out in the periphery. Curly A lines are larger and more centrally located. They both represent interlobular septal thickening. So let's blow up another area here. So kind of going a little bit deeper, this is like inception, just a little bit deeper into this radiograph. We'll blow up another area. So we blow up that area, and what do we notice here? We see that there's a vessel, and we see that there's an airway. And if we look at this airway is just, again, too thick. These airways should be paper thin. So we can see that there's thickening of the airway. So this is what we call peribronchial cuffing. And why do we get that in congestive heart failure? It's the same reason why we get thickening of the interstitium. Fluid is leaking out into the interstitium of the lung. And one of the interstitiums of the lung is the bronchovascular interstitium. So you're going to get airway wall thickening, right? This can cause bronchial wall thickening, can lead to wheezing, right? So this is like the cardiac wheeze, right? So you can see airway wall thickening. This is what you say is peribronchial cuffing. It's airway wall thickening. Same idea as curly. In addition, what do we notice is that the vessel, so the artery adjacent to the airway, has increased in size. Normally these are around 1 to 1. You can see that this is much larger than 1 to 1. And this is another sign that there's backing up of fluid and elevated pulmonary pressure. So this is what we say is an increased pulmonary artery to bronchus ratio. So let's go on a little bit further. So this is again a person with congestive heart failure. You can see the septal lines out on the periphery. You can also notice that there's peribronchial thickening, so peribronchial cuffing. In addition, you could also see these lines emanating from the hilum. So this is an example, again, of interstitial pulmonary edema, curly A, curly B, and peribronchial cuffing. However, there's another sign that's also present. And I think to best illustrate this, we're going to put up a normal radiograph adjacent to the abnormal radiograph. And then we're going to blow up this area in here. So we blow up that area in here and we compare it to the normal radiograph. If we look in here, so see all the vessels, see how nice and sharply marginated they are, right? They're really easy to see. But where are the vessels on the other side? You just don't see them. The vessels are indistinct. And this is what we call as hilar haze or vascular indistinctness. I had an attending back in the day that used to say, just give him the haze. And I'm like, what does that even mean, give him the haze? What does that even mean? And what he was talking about is it's an actual sign, and it basically means that there's indistinctness of the central vasculature. If we compare the vessels over here to the vessels over here, we just don't see them well. They're all kind of blurred out. And this is a sign of interstitial edema. There's vascular indistinctness from fluid leaking out around the vessels. It's causing the vessels to be indistinct. So it's an example of hilar haze, another sign of interstitial edema. In addition, we can see that there is thickening of the minor fissure. So here's the minor fissure there. This is what we say is fissural thickening, another sign of interstitial edema. Fluid is leaking out into the lung interstitium, lymphatics are picking it up, and they're draining it out into the pleural space. So we start to see fissural thickening. So this is the thickening of the minor fissure, another sign of interstitial edema. And this is what this looks like on CT. So on CT, what do we see? So we see all these lines. And what do these lines represent? These lines represent areas of intralobular septal thickening. So intralobular septal thickening, the short lines out here represent your curly B lines, the larger lines more centrally represent your curly A lines. This is what we say is intralobular septal thickening. In addition, if we look at this airway in here, this airway is just way too thick. It looks like a Cheerio. If we compare this airway to this airway over here, so look at that airway over there, look how nice and thin and smooth that wall is compared to the airway over here. This airway is just way too thick. And it's the exact same idea. We have fluid that's leaking out to the interstitium and fluid that's leaking out into the bronchovascular interstitium. That can cause airway wall thickening. This is why they can wheeze or have air trapping. It's because the airways are so thickened. So this is an example of what interstitial edema looks like on an axial CT. And on a coronal CT, it's kind of nice to see what these curly B lines look like. And so see these lines out here? Again, these are areas of intralobular septal thickening. And these are all our curly B lines that we initially saw on that chest radiograph. In addition, we also notice that there's wall thickening, again, of the airways, right? This is your peribronchial cuffing, right? So peribronchial cuffing and curly B lines. This is an example, again, of interstitial edema of what it looks like on CT with intralobular septal thickening and air wall thickening. All right, so let's now move on to airspace edema. So airspace edema, we're talking about alveolar opacities. We're talking about fluffy stuff within the lung parenchyma. Okay, now fluid is leaking out from the interstitium and filling up the air spaces, right? So this typically is going to be symmetric and bilateral. Sometimes, though, it can be diffuse or patchy. And it can have a batwing distribution, and a batwing distribution is, typically perihilar. Okay, so perihilar in distribution, like we see here. However, a true batwing appearance, where we don't see the vascular congestion, where we don't see the septal lines, it's fairly uncommon. It represents only about 10 to 15% of cases. But this alveolar edema tends to be more centrally located, and the reason for that is because the lymphatics are really robust out in the periphery of the lung, and so they can have this peripheral clearing. It actually pumps all the fluid out of the lungs, into the pleural space, into the lymphatics. And so you kind of get this peripheral clearing. And because you get peripheral clearing, you have more central opacity, right? And so it's this central opacity, these fluffy opacities in here. And there's an example of that where we see this kind of fluffy stuff within the lung parenchyma. And we see that there's other signs of hydrostatic pulmonary edema going on. We notice that the vascular pedicle is too wide, the azygous vein is super distended. We can see some subtle curly lines out in the periphery of the lung. There's vascular indistinctness. However, we also note that there's these fluffy opacities. There's fluffy opacities, perihilar in distribution. This is an example of alveolar edema. And we can see how, as the patient is getting better and is being diuresed and they're getting their congestive heart failure under control, how the vascular pedicle is getting smaller in size, the vascular distinctness is becoming a little bit less. We can actually start seeing some vessels centrally, and then the airspace opacities look a little bit less evident. The patient now, you can see the vascular pedicle is basically back to normal. We can see that they placed a pacemaker and a Swan-Ganz catheter. And if we look at the vessels centrally, we could start seeing vessels, right? Before, remember, the vessels were all obscured. We couldn't really make out the vessels, right? The vessels are becoming more evident. We start to see them better again. And that's because the fluid is being taken off of the interstitium. They're no longer being obscured. And then we can see now that the vascular pedicle width, again, it's a little bit wide, but it's getting back to normal. The vessels look certainly distinct. We don't see a lot of curly B lines, but what we do see is all this haziness down here. So see all this haziness? This is not pulmonary edema. This is pleural effusions, and it's not uncommon that pleural effusions develop after or subsequent to the pulmonary edema clearing. And that makes sense, right? Because we have all this fluid in our lungs. The body wants to get rid of the fluid. So where does it put the fluid? It puts the fluid in the pleural spaces. So you can actually see improving features of pulmonary edema, but worsening pleural effusions. And this is not uncommon. We see this fairly common in the ICU setting where they have really bad congestive heart failure. The fluid starts getting better, comes off of the lungs, but goes into the pleural space. And you can actually see that they've developed pleural effusions. So in review, we really talked about just hydrostatic pulmonary edema and how it's phasic and corresponds to wedge pressures. We go through this characteristic progression of vascular congestion into interstitial edema, and then finally into airspace edema. And we saw specific signs for each. Remember, for vascular congestion, we talked about vascular pedicle widening, azygous vein distension, cephalization and vascular redistribution. For interstitial edema, we talked about curly lines, visceral thickening, peribronchial thickening, and hilar haze. For airspace edema, we saw these kind of fluffy perihilar opacities more centrally within the lung. Now, it's also important to remember that the heart may be enlarged, and that makes sense, people that have dilated cardiomyopathies, but not all the time. Not all the time is the heart going to be enlarged. If they're in acute renal failure or they're getting aggressively fluid resuscitated, the heart may not be big. In addition, if they have an acute myocardial infarction, the heart may not be enlarged yet. So the heart does not have to be enlarged. And again, don't forget that pleural effusions are very common in this scenario. The body's clearing the fluid. It can put it into the pleural space. They could also be third spacing, accounting for the pleural effusions. So you can see pleural effusions even as the pulmonary edema is actually getting better. So that concludes this talk. If there's any questions, please feel free to email me.